Dr. Rao, can you hear
Ah,
us?
I
Yes,
can
yes.
hear you.
Yeah,
Uh-huh.
we have Dr. Kinjo
I'm
Veda.
Skinzo Veda.
Yeah.
I can
Great.
see
Good
you on the
morning.
screen.
Good
Good
morning,
morning.
Kinjavida and my colleagues, all Japanese
Mhm.
colleagues. Great. First of all, I thank the CTO organizing committee to give me
Mhm.
this opportunity, and also thanking for the great success of IJCTO because of the Japanese faculty. I
Thank you.
thank you again and again. And so my colleague, Dr. Sachit, today will tell you about the clinical history and the angiogram findings.
Good morning. I am Dr. Satyajit from Apollo Hospital, Hyderabad, India. Uh, Case of a 53-year-old gentleman known as hypertension admitted with class 2 angina. TMT is positive for indicible myocardial ischemia with normal LV systolic function. His past history of infralateral wall MI, primary PTCA with stent to LCX with drug-eluting stent, and RCA distal CTO attempted failed to cross 6 weeks back at different hospital. His serum creatinine is normal, EGFR is normal. RA caudal view shows LMC normal, LCX stents patent, and LCX shows epicardial collaterals. They are cos Q collaterals to the PLV branch. RAO cranial view shows type 3 LAD and proximal ectasia, mid-mild disease with septal collaterals from LAD to second PDF filling up to the bifurcation. Collaterals CC1 and CC2. LAO cranial view shows distal RCA total occlusion, and we can see the distal end of the CTO ends at the bifurcation of PD and PLV. So LAO caudal view also shows retrograde filling of the RCA from the left system, and the CTO ends at the bifurcation point. LAO view shows RCA distal total occlusion with the tapered tip. RCA is a dominant vessel, and it's a total occlusion. Then confirming the RM view also with the JCTO score of 2. Thank you. I will hand over to my senior colleague, Dr. V. Suryaprakasa Rao.
Dr. Rao, this is Dr. Kane.
Ah,
I just,
Good morning,
yeah, just
please.
Dr.
the
Kani,
full hall here for
just,
you, and we have a very good panel.
yes, yes.
So I would like you to tell us what is going to be your strategy.
Dr. Kani, actually the primary
Antihepatic
strategy
injection, LAO
because of distal bifurcation and proximal non-tapered stump, initial intended strategy is a retrograde approach
retry.
and then followed by antegrade preparation. We want to connect the two channels.
Use the stents.
Initially we have taken the 7 French both sides arterial axis, femoral
PDA.
axis, and then 7 French EVU catheter to engage left coronary artery, and right side with side holes 7 French amplage AL1 catheter we engaged, and we took bilateral injections so that we have reasonable collaterals, but distally it is very much angulated collaterals. We want to show that one step by step. Dr. Rao will explain, and next Dr. Rao will explain all the steps what we underwent during this journey of the process, and ultimately we cross the CTO. Dr. Suryaprakasa Rao.
Dr. Kani, Dr. Veda, here we have first given a simultaneous bilateral injection. You can see that there appears to be, because it's a retry case close to the bifurcation, and there is a calcium plaque. That's the reason the first attempt must have failed. So we have got the RO caudal and RO cranial simultaneous injection, which showed very promising collaterals. So first, particularly the second septal, with some branching directly joining one of the PDs. There are two PDs like, and the second PD it is joining, and other collaterals are not that encouraging, as We have moved with a 150 Corsair with a cyan wire. Next. And we could enter the second septal easily. Next. We have given a selective injection here. You can see a dividing thing on the lateral side branch appears joining the bifurcation. Next. We tried with here we changed to a CO wire because a lot of bends tortuosity down, but unfortunately we are not able to reach the target there. We have given multiple selective injections, never damage the collateral, but you see there are multiple channels there dividing branches. Next. We also tried to a cyan blue, and we also tried cyan black, and we also changed it to first septal, which also appears, this is again second septal. Next. This appears to be a direct channel, but somehow even the CO, there is a difficulty in crossing the channel. Next. 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 This is the first septal, but the distal exit points are not good, so we came out. Next. And we tried a third septal also, which is directly joining the PD, but there are mesh of collaterals. If you see that, and this is not a good connection. They are all mischievous. They are not as they appear. It's not practically to cross them. It's not possible within CO. This is the third septal. There is tortuosity distally, and that exit point not happy. I documented with the wire also there. Next. Next. So we are monitoring the ACT and keeping above 300. A small septal injury, but it's okay. It healed, and now we tried for the antigrade with 135 Corsair, and always I try to enter with a floppy wire when the bend in the RCA is there. So after that I exchange it to a fielder XTR wire. This is an amplage AL1 with side holes. Next. So the fielder actually finding very difficult. It's very hard plaque. That is the reason the first attempt failed at a different hospital. Next. Then I tried GAIA1. Yes, there is a bend, and I know there is a risk at this bend I can go into false plane, but I pulled the Corsair little back and made some adjustment. Next. I am close to this thing, but here also very tough, and the wire is bending, so I have to change to GAIA3 here. Next. I checked it in RA view also, and it appears promising here. Next. So with the GAIA3 I could cross the CTO segment. Next. I checked in 2 oblique views. Next. And finally I could enter the PDA. A PLV is a very big branch here, but we entered the PD here. Next. Now we we try to pass the Corsair distally, which is impossible because of the calcium. So we, with a balloon trap technique, we pulled the Corsair out, and we tried to dilate with a 1 millimeter sapphire balloon. Finally it could cross the lesion, the 1 millimeter sapphire. Then after that we went to the 2 millimeter balloon, which is a mini track 2 into 10. Next. Then we exchanged the Corsair with a balloon trap technique. Now and with a floppy wire, I am at this stage. Any difference of opinion or hello?
Hello, Dr. Kani.
Not able
Yeah,
to
yeah,
hear.
yeah, we are-
You are able to hear, I think. Okay. So
Yeah, we are able to hear.
Yeah.
And, it's an excellent demonstration. Yeah, we just wanted to a little bit discuss. That's what Dr. Veda felt.
Yes.
So what?
Gaia wire can pass the lesion.
GAIA3
correct?
can pass, GAIA3.
Third.
Gaya third.
Your wire escalation was
Escalation of wires.
XTR, Gaia third.
Gaya third. So we'll go
Yeah, is there any
2.5
comment
below.
from the commentators?
2.5 below. We'll take 2.5 below.
Surya, we are going to ask some comments from the commentators.
Please,
because let's
please.
on their participation.
2.5.
About the scepter channel negotiation.
Crusade.
Exactly.
Dr. Ishka, is there any comments?
Crusade, we'll take a crusade.
క్రూసెడ్ తీసుకోండమ్మా తీసుకొని ఇంకో సియాన్ తీసుకొని ఎంటర్ అయిపోండి
Thank you.
Crusade.
క్రూసెడ్
Thank you.
చెప్పండి
Okay. So, you mean the retrograde channel trap?
Yeah. Scepter channel negotiation.
If I do the retrograde approach in this case, so second sector is a very good channel for the retrograde approach. But so we can see cranial view only.
Cranial and caudal we have seen too.
Caudal aerial view is very important. Maybe so looks so like straight, good collateral channel, but another direction. So tiny,
Corkscrew?
No.
yes, corkscrew, like so.
He
But in this case, I start the anti-grade approach because so CTO region is very short, but not just bifurcation.
Yeah.
Proximal part a little bit length.
And the type of the CTO tapering.
It's
Maybe
not that tapering, it is like
Tapering?
some small channel like coming from that, and it's not that tapering. Okay.
The cause of the difficulty of anti-grade wiring is the bending
యా ఇప్పుడు
for
No, you
CTO. Correct?
See,
yeah, exactly. It's a bending actually. Prior to cap, it is small bend was there. So
CN
the wire
yeah.
may be directed towards the non-tapered side, and distal branching is there, PLV and PDA with a very small stump. So that's why our intended strategy is primary retrograde.
because
But
of the
unfortunately, yeah.
retry and the bifurcation,
Yes, yes.
that's a risky thing. That's why I tried. But two channels appear very promising.
Yes.
But unfortunately,
But
none of them
yes,
are the
branching
exit
points are
points.
there, mainly. It is angulation plus branching points. Always it is going into the non-connecting branches.
As I said, maybe a rotational angio or different views could have helped me. What do you feel, Dr. Veda? What is your choice? Anything difference you will do in this case?
I think as per the algorithm, you had a long segment CTO with a bifurcation. There was a band and a little bit of an ambiguous proximal cap. That's what, as you felt it. The retrograde approach to start with was an ideal approach. And unfortunately, how often do we see that? At times we do see that you just can't get through the collateral because it's not joining, and then you do surfing, you try different collaterals. But there are occasions when you don't find it to connect it to the branch that you want to, and
make a
then an anti-grade
bend,
approach becomes sort of
Secondary bend.
preferred
Secondary.
now because
Ah.
you are not able to get through the collaterals. That's what exactly what Dr. Rao is saying, and he's tried 3 or 4 collaterals,
Yeah.
and he could not enter the PDA.
I can dilate
So
it
I think
2.5 billion.
the
Just
approach
take.
to anti-grade was fully sort of
Yeah.
acceptable.
Yes.
And how would you, Dr. Veda, proceed in this? Means he tried Filter XTR, and then I think he went to Gaia 3. I don't know whether he tried Gaia 2 first, but then
Two also tried. Gaia 2 also tried.
2 also.
Yeah.
Most of the people nowadays, Gaia 1 is now almost when you start following a soft wire, you go to Gaia 2 rather than Gaia 1 because with experience, people have moved to Gaia 2 as a straight. What do you have to say?
Is there any comment
Is there any comment from the
about
commentators?
selecting the anti-grade
Yeah.
wire?
2.5 is 10 cases.
Habara? What is your selection?
Yes, that's
I,
what it-
I agree with Dr. Rao. At first, I use XDR, and so after that, step up to the Gaia first and the Gaia second.
Guys, second.
Yeah.
Gaia first, Gaia next first.
Yeah. So in Japan, actually, we are changing to the next series. Gaia is changed to the Gaia series. So that's recently I
Okay.
use the XDR, and the next choice is the
Both
Gaia
ways,
next
both
one,
ways.
and then
Mm.
after that, the Gaia next second.
So we do not
Now
have
we'll
the
take on
luxury
this.
of having Gaia
Open.
Next in India, and
Both
it's not
ways.
available. So we choose the
బాబు
standard
ఒక్కసారి
Gaia.
బాబు PL
How about using the XDA?
You know?
Actually, in recently, I don't use
అది కాదు ఇది కాదు ఇది
Oh,
ఆపోజిట్
no problem, no problem.
పిడి
Let it be.
sometimes
No problem.
when I perform as a
Now
retrograde
I'll
approach,
lower
XPA is also
రెండు
sometimes
వైపు
very
switch చేయాలి.
good.
Open చేసి
Antegrade approach.
both ways.
Both ways,
Hold
sir.
it. Hold both
Hold
ways.
both ways, please.
But use the Gaia series.
అదే చెప్తున్నాను.
Another comment?
వైర్ ప్లీజ్ దాన్ని
Yeah.
పుష్ చేయండి దాన్ని పుష్ చేయాలి మీరు ముందు రేల్ని ఎస్
Mike,
బోత్
Push చేసి
ఇక్కడ హోల్డ్
చేయాలి.
చేయండి చేసి
పట్టుకోవాలి నా వైర్ పట్టుకోవాలి.
నేను పట్టుకుంటాను
can you help?
ఒక్క
Can you help her with the mic?
జస్ట్
1 minute సార్ అయిపోయింది నేను పట్టుకుంటాను నౌ యూ హోల్డ్ ఇట్
Dr. Suryaprakasa, you proceed with your procedure and tell us later. We are just discussing because Veda has
Okay.
raised
Okay.
some. You can stop us and come back. Anything that interesting that you want to show us.
షూర్
I just used the crusade catheter to get into the other major branch in this case. That's I have done. You must
Okay.
observe there is a large branch, so I want to protect the bifurcation. I used the crusade and got into the other branch.
You explained as the lesion has calcium
యా
Calcium.
How about
That's why.
of the rotated in the case.
If not turnus, I would used then as you said.
No, here the calcium is only minor speck of calcium, not a major calcium to need rotablator. So just it yielded to 1 mm low profile balloon as well as followed by 2 millimeters balloon dilatation serially. Then they took the
14.
crusade to cross the CTO and to wire the major branch for protection. And it is a speck of calcium, not a
2.5
major
balloon
calcium necessitating the rotablator.
2.5 billion తీసుకోండి. 2.5 billion తీసుకోండి.
Are you planning for any imaging or you?
We are doing
happy with-
imaging, sir.
No,
we are
we want to
doing.
do IVAS to
Okay.
know the size.
So, madam, you were commenting on something. Can you go ahead with your comment?
2.5 billion.
What I think escalation of the wires, I think you have to do it systematically when you're doing for the first attempt. But this is already a failed attempt. So probably we need not to go for a low profile or non-penetrating or a simple softer wires first and then escalate to the subsequent ones. I think in this directly from this in XT,
2.5 billion.
already tried. Directly probably I will go for the higher one like a Gaia 2 than a Gaia 1 and then going to the Gaia 2.
Time అయిపోయింది.
That is
Just-
one. And about the retrograde, I think is a fair attempt was given to the crossing the 3 septal collaterals. And it is astonishing that it is communicating the distal, demonstrating the distal vessel filling, but not able to pass through that. This happens very rarely. And he already tried the CO wire, which is the softest wire, which can go through the really collaterals. I think after the appropriate attempt of the antigrade, he tried for a failure of the retrograde, he tried for the antigrade.
Yeah, absolutely.
No,
yeah, that's what-
Dr. Kane, here
Yes,
the
yes.
septals basically it is branching points are there. That is a major negative point. So whenever you try to
that's
cross
what we
the
are
angulation,
discussing. When other
Can-
situations where
practical
probably
difficulties
you feel
actually.
like that
Yes,
you
yes,
cross
exactly.
retrogradely.
Practical difficulties we
You IVAS,
faced.
please.
Obviously, there are times when crossing retrograde after multiple attempts, also you cannot connect,
Exactly.
and then you go antigradely. It
Yeah.
happens at times.
సరిపోతుందా కొంచెం చేయండి. చేయి. IVAS, please.
Then, after crusade and branching the
fast
wire
చేయగలవా?
systematically with the high pressure dilatation was done. Now we are doing IVAS actually.
Fast.
How is the pathology of the CTO, fibrous calcification, everything we want to observe, and sizing of the distal vessel also we want to assess.
Put the
So
IVAS.
this image becomes vital when you have
Yeah.
especially a long CTO, to know what's the exact dimension of the vessel and what is the pathology, what difficulties you might encounter during stenting, and which stent to prefer. What do you say?
Could I just have a comment, Dr. Veda?
Oh, yeah, please go ahead.
Now, Dr. Surya, can you hear me?
Please.
Very early morning for you there. Very
Yeah,
nice
we
to see
started at
morning in the
5
lab.
o'clock. All the
And,
staff
who
cooperated.
is there? Dr. Kapardhi yourself.
Yeah,
So
Dr.
very
Vishwanath.
early morning in India, and I want to congratulate you, sir, Dr. Surya. This is the first time an Indian has come to Japan via a transmission. So Dr. Kinzo Veda,
I
our
should be
sensei,
thankful
has-
to the CTO committee, Dr. Veda, Dr. Nasu, Dr. Suchikeni, everybody there.
No, my question is, I think you are absolutely correct, because the previous anti-grade
Please,
attempt,
let me-
particularly in the bend and the tortuosity, we would be little scared to cause further damage, particularly it's
hand
only
hold.
6
Hand.
go.
Somebody hold his hand.
And the retrograde approach was tried and abandoned, and then we had to go to the anti-grade approach.
Yeah.
Okay. I am doing from the
unfortunate thing
distal
is
to the
I am
proximal.
next
Now the
month.
IVAS being done, focus on the IVAS. The second wire is seen there, and the side branch. Now it is in the true
started like
lumen
bifurcation.
IVAS, exactly.
at the bifurcation site. There is a big side branch there also. That's only eccentric calcium from maybe somewhere 9 to 12, and at the 1 o'clock,
Yes.
and
now
again at
chunk of calcium.
calcium
3 to
from
4.
1 to 4.
Oh.
I think yes, there is a calcium that. That's the reason I think this lesion, even though it is a short segment, troubled. There is a calcium even at the mid artery also. It's a concentric calcium.
Yeah. Okay.
So can somebody show me what is size of the vessel? At the distal end, what is the size of the vessel? Open, open.
Dr. from Korea, congratulations for your successful negotiation of the entry the wire.
Thank you, thank you.
Because this was initially failed entry with approach before. So primary retroid was attempted.
I don't know. It is the first
according
attempt?
to the comment.
Is this
Okay.
PCI?
It's a take
Second
long
No,
stent,
it
no
was
problem.
attempted in another
Give a long
hospital,
stent.
and
Long
a few
stent
weeks,
from the
6
mid
weeks
artery.
before, now the patient
Three
got
size.
transferred.
Is it 3 size? See this?
So primary
Huh?
it will be more safe once there's a good collateral channel. However,
2.5. 2.75 you can give long stent, whatever.
The main
Point
PD
five
we
Limit
can
is
here
go.
to here.
the one
This
We'll
way
stop
we can
here.
put
Are
there.
you-
We can
We'll stop at that.
important to delineate the distal
PLV
communication.
location
So that
mountain కదా PD location
leg over and before the starting retroid wire. And at this moment, once entered the subject,
Come to the
I
LAO,
usually
please.
remove retroid guiding, and there's a still chance of a catheter-induced injury or the
I know.
thrombosis, flowering, and after once the entered approach is successful, then just checking the
deviation.
channel
No
injury,
problem, we'll put it there.
then
Give another wire.
ఈ వైర్ పైన
Another BW wire. No.
ఇది బ్రాంచ్ కాబట్టి
Give the torque,
How about-
I'll put it in there.
ఇటువైపు పెట్టు, ఇంకో
other
వైర్
stuff.
కింద వైర్
You keep the entry to guiding like this.
That will protect both, sir. Now we are not touching that anyway.
Remove the proceed.
No, no, I will send it. Nothing
Yeah,
like that.
yeah,
Give
I
the
think,
send.
you know,
Give
an
the
access
send.
from
I will send it. Nothing will happen.
what your suggestion is well taken.
Give me another wire. I will into the TLV. No harm.
Dr. Rao?
Please.
Yeah, first wire, same.
Please, I am able to hear. I am able to hear.
Yeah. One of the here suggestion is that once you have got access from integrate side, he says that he would remove the retrograde equipment after checking for
It
channel.
is not there. Actually, it is in the guiding catheter only almost.
wire.
Yeah.
Except the wire. LED wire I kept because I want to check it at the end. That's it. No Corsair, nothing in the system.
Inside the
Absolutely,
guide.
yeah.
Inside the guide.
What you are
It's
telling?
been
So best way is to check in the channel injury by the entry with Corsair. Then if it's okay, then it's better to remove it.
Yeah.
Otherwise, sometimes, you know, even good ACT maintenance, sometimes catheter, inside of a catheter, the thrombus can be formed. And sometimes you have to irrigate or the filling of contrast to prevent
Yes, I agree with you. I agree with you.
the thrombus formation. So it's better to remove it and do
Yeah.
the guiding.
Thank you for
Thank you
the
for your
remote.
good suggestion.
Remote.
కొంచెం ఇంజెక్షన్ ఇవ్వన్నారు
Sister, anti-glide injection. చూసుకోండి sister.
యూ గాట్ ఏ విస్పర్ వైర్
ఇది అదొద్దమ్మా, అది కాదమ్మా. Anti-glide.
ఒకటి విల్ హ్యావ్ ఎ బెండ్
So when you decide the distal landing zone of the stenting, this is a big
difficult
bifurcation. So after the, how did you decide it? The distal landing zone by the.
I have to cover all the branches. మాట్లాడుతున్నాడు ఒకటి
Actually, we want to place across the ostium of the branch. We want to put the stent, the distal landing zone. We want to put across the ostium of the branch.
the PLV.
Yeah. Because PLV is arising with an angulation from the PDA. Yeah, night vent. Yeah.
Okay.
So we protected the PLV now.
We protect it. Now give the stent, sister. Long stent you can give.
So you are going to start in the PDA beyond the PLV. Is that what you
Exactly. Crossover across PLV.
Long stent 2.7. I will see the again. Check it. You can give. What is the size distally? Vessel size?
I was.
I think 2.75. You can give a long stent. Please.
One of the things that Dr. Ra mentioned was despite the AC thrombosis in the system, but we always keep check 10 minutes. Every 10 minutes, we
Every
keep
10
flush-
minutes.
We are
10
checking
minutes.
Yes.
every half an hour. We are checking, not 10 minutes. Every half an
Dr.
hour.
Vishwanath, we want to keep ACT around 300.
We check ACT
Yeah.
30 minutes, and we keep flushing the catheter every 10 minutes.
every 10 minutes.
So we can see
It's
that,
very important for preventing the complications.
flushing of the catheter every 10 minutes make sure that unfortunate things like
Most vital.
thrombosis,
Most vital.
are said, is not there.
One good way is to fill in contrast into up to guiding tip.
Okay.
The contrast filling disturbing the thrombus formation
Okay.
instead of the friction.
Right.
Injection sister.
But I think if your ACT is beyond 300, I won't think that I won't even think of thrombus forming just because the catheter is there. But your point is well taken. You don't need it.
And
That
even
point is well taken. But if your ACT is beyond 300, have you seen any thrombus? But then there is no end to this.
even the
Because
successful retrograde and the externalization and working on the entry approach,
yes.
it's better to little bit pull back retroid the guiding catheter from the osteum.
Guiding
with the dye.
So always.
But then you won't get pressure because getting the pressure and watching the pressure would be the most important parameter to know if there is any wedging, if the guide catheter is entering inside. So if you fill it with dye, would you get pressures? How do you do that, sir?
So my opinion is always not only the pressure monitoring, but also safe procedure.
Give injection now. Like this.
So catheter-related left main osteal injury or the thrombus shower.
We'll come back.
I'm little bit
Fine.
pulled
Osteum
back
is
from the osteum during the retroid enteroid.
No, Cardal, please come to Cardal.
Feel saline or contrast.
Yeah.
I want to feel saline in the
Saline
guiding catheter.
cannot see clearly, but the contrast we can see. Oh, this is a no chance of blood clotting due to
Give another stent.
contrast.
Give another stent. 3 into, no. We'll cover it.
Blood or the cell line. So my way is
3
always
into 28 each.
the guided catheter.
Maybe contrast sometimes make some thrombus.
I don't think so. Pure contrast. We have done many times.
We use contrast with heparin.
Yeah, already inside the heparin is enough.
Oh,
Yeah.
it's one way. Yeah. Okay.
Have you done that before?
We are given some anti-G. Will tell you stent it.
The guide and a continuous small amount of irrigation of the fluid continuously, that will
Holding.
help in any way in the thrombus formation. Continuous irrigation of the normal saline through the guide. Disengage the guide.
In the case you need motorized infusion
We'll remove
pump
one wire system.
against the
PLV
arterial
wire
pressure. But
దీని మీద వచ్చేసారు
it's a simplest
అదే
path.
చెప్తా ఏ వైర్
Simple, quick,
చెప్పండి ఏ
safe.
వైర్
That we should pursue that.
ఏ వైర్ తీయాలి
అది
ఇదేది
అదే పిఎల్వి అనుకోండి చూడమ్మా ఒకసారి చూడండి
Let me claim my ignorance, but we have never done this. I have not seen any.
దీని మీద వేసారు
ఇదే సార్ ఇదే పిఎల్వి
చెండి దీన్ని
You put
So I'll
contrast
close this
into
wire.
the guiding
Correct
catheter
analysis.
and keep
కరెక్ట్
when you're not using the retrograde side.
I want to
I
use
think if you have a good
saline.
pressure and if you have a good,
yeah.
obviously good pressure and a good ACT, I don't
From
think that should be
contrast
anything more.
Contrast to feeling no problem to monitor.
Okay.
And then
Maybe a good idea. We'll try it.
Yeah.
Give me
I have
small
done more
cup.
than 10 years. That
Okay.
way.
Yeah,
Great.
sounds
Yeah.
good.
Yeah.
give injection
Appreciate.
లాంగ్ స్టెంట్ యా
కొంచెం పుల్ చేస్తాను ఇచ్చేసి సిస్టర్ ఇప్పుడు ఇవ్వండి స్మాల్ పఫ్ చేసి ఒక్కసారి ఇంజెక్షన్ కాడాలి కదా బాబు
హలో డాక్టర్ కాని
Yes. Go ahead.
Actually,
And
after putting the stent across the PLV, the ostium of
Yeah.
PLV is well preserved, but the guiding section is slightly
Go to
sucked
LAO.
and produce proximal dissection. So we want to cover with the second stent, proximal segment we covered now, with a stent overlap. This is the one you can see.
So you are doing the proximal stent first. You already done the.
No, now we are putting the second stent overlap, and we are dilating.
This is one of the issues. I think when you use
It's for
an
long
implant,
stents, especially.
maybe sometimes you
Ah.
have inadvertent plaque which you sort of raise and you start
Okay.
having
Yeah.
a dissection.
చేసి
Especially when the long stents are used, there is a tendency for suction of the guiding catheter. The guiding catheter problems will happen when we are removing the long stent balloon.
go to 3 take a 3 balloon
No, we want to do with a high pressure dilatation. Yeah.
Which stent are you using, Dr. Suryaprakasa?
this is a Jain's expedition
Jain's expedition.
Jain's-
Yeah.
Nice expedition.
3 by what's the stent?
the distal one is 2.75
Proximal
above one
three.
is 3
3.
and the IVAS it came 3 so
Yeah, absolutely.
In India, Alpine is not available.
Alpine it was available, but it just taken away by. We have
Go
a
to
very, very
cranial.
interesting India because of the pricing of the stands has been reduced remarkably by the government. So there is some discussion going on between companies and the government.
I think that Kane, now you can see the proximal stent also placed with the overlap, and all the branches have been preserved. I will do some high pressure dilatation in the stents and overlap area.
Absolutely.
Oh,
Good.
good result.
Thank you, Dr. Veda, for your all blessings.
Dr. Rao,
Dr. Kane and other my colleagues,
for your nice,
my
excellent
Korean friends, and everybody there. Thank you a lot for the opportunity.
Thank you very much.
Excellent demonstration, and we're very happy for a good result, and all the best for the remaining part.
Thank you. Thank you.